Okay, so next is uterine rupture. Uterine rupture is when the layers of the uterus are disrupted, and for it to be a rupture, all of the layers. Now, sometimes we have dehiscence where there's a partial separation. Some layers separate and the rest remain closed. That's more common, and sometimes that even is undiagnosed because it may not be symptomatic. But a complete rupture is when all of the layers of the uterus are disrupted. The risk factors, any patient who's had a previous uterine surgery, that is a risk factor. That includes cesarean. Now, that risk is a lot higher if the scar is in the fundus, because that's the part of the uterus that has the most pressure. That risk is lower if the incision is in the lower transverse segment of the uterus. The lower segment of the uterus, that low transverse C-section, that's the lower risk. That's why a patient who's had a well-healed low transverse C-section may be eligible for VBAC. Another risk is uterine tachysystole. If we have too many contractions, too close together, too long, too hard, that can cause the uterus to rupture. And if the patient is laboring, but there's some mechanical obstruction, like the fetus just won't fit through, ongoing protracted labor against something that won't move can cause uterine rupture. What are the risks? The mother can hemorrhage and bleed out because of that rupture. And we can also have fetal demise or hypoxic brain damage. So uterine rupture is an emergency. For management, prevention, first of all, if the patient has a history of a classical uterine incision, that's going to, a uterine incision that is up in the fundus in the top part of the uterus, especially one that's going, a vertical incision. But any incision in the upper part of the uterus, if they have that history, they should not have labor. They should not labor. They should have a scheduled C-section. For detection, any patient that has some increased risk, so if they have a previous incision, but it's considered to be in a less risky area, we're still going to monitor that patient more closely. And we're monitoring for increased pain and pain between contractions. If they're hurting and the pain doesn't get better between contractions, the contractions either get a lot harder and closer together, especially a lot closer together, or they just stop altogether, because when the uterus tears, it may respond by contracting more, or it may respond by just quitting. Okay. Changes in the fetal heart rate. What would you expect to see if the fetus has a sudden interruption in blood flow? So you might see a big decel. A sudden change in the uterine shape. If you've been looking at this patient in labor and suddenly their abdomen looks different, we need to check that out. And the fetus may look like it rises in the abdomen. If the rupture is complete and the fetus actually exits the uterus, we may see the fetus look like it's a lot closer and move up in the abdomen. We also might see signs of shock in that patient. What does shock look like? High pulse, low blood pressure. Mom's going to feel crappy, fainting, weak, confused, pale, those kind of things. Okay. So what do we do if we see this? If we see signs of uterine rupture, that is a don't leave the patient, call for help situation. Okay. That is a situation in which we are observing something we need to, that needs to be addressed. So we contact the provider, stay with the patient, prepare for an immediate C-section, be prepared for maternal and neonatal resuscitation, including possible massive blood transfusions that can lose a lot of blood. So the blood bank needs to be involved in that preparation. Okay, the next one we're going to look at is amniotic fluid embolus.